Welcome back. We're going to continue our conversation on the therapy of infectious and parasitic disease. This time we're going to look into some miscellaneous antibacterial drugs, starting with the fluoroquinolones. Fluoroquinolones are broad-spectrum agents. They have multiple applications depending on if they are of the fluorinated analogs of nalidixic acid, which can be used more broadly, or you might have to consider a narrow spectrum quinolone, which is used only for UTIs, and we'll talk about which one that is in just a second. And the benefits of using a fluoroquinolone really has to do with the ability to disrupt DNA replication and cell division. They will not disrupt the synthesis of proteins or affect the cell wall. Okay, so it's all about DNA replication and cell division. All of the systemic fluoroquinolones can be administered orally. So that's another benefit of using a fluoroquinolone. And this is why many people like to prescribe it and many people like to use it, especially when they prefer not to just be on like an IV antibiotic. Side effects are generally mild. However, these are the things that are going to be what you're thinking about the most and educating people on the most. Fluoroquinolones can cause tendinitis, tendon rupture, and it will sometimes cause Achilles tendon. Okay, but it's a very low risk, but I always bring this up when I'm prescribing to my patients. Resistance is very slow going as well, but when you are using it against Neisseria gonorrhea, it becomes a little bit more common that fluoroquinolone is resistant to this. And because of this, in most areas of the country, we won't use fluoroquinolones on gonorrhea infections anymore. There are 6 fluoroquinolones that are available, but only one that we use for topical eye treatment. We don't want to prescribe this drug to patients that are under 18 years old, and there is a risk to all patients, obviously, but those that are older than 60 years old and are taking a glucocorticoid and they've had maybe kidney, heart, or lung transplant, you do not want to give this medication to. You can see the 6 systemic fluoroquinolones that we can prescribe. Ciprofloxacin we use commonly for complicated or repeat UTIs that are resistant to the other broad spectrum antibiotics. We'll also use levofloxacin for UTI again, and ofloxacin we can use for UTI, but it's less popular for prescribers to provide this. So depends on if they've been on the other ones yet or there's resistance. As far as pharmacokinetics, these drugs have hepatic metabolism primarily. They're eliminated by the renal system. And again, the adverse effects that you're looking for are the rare ones like tendinitis, tendon rupture, but there could be some exacerbation of muscle weakness and peripheral neuropathy and phototoxicity. The drug interactions are really important for Cipro and Levaquin. If they are on antacids, calcium supplements, milk, dairy, iron, zinc, or sulforaphate, you will not prescribe this medication. So if they have some type of GI GERD, I'm probably going to ask if they're taking antacids, whether they are prescribed or not, and oftentimes they may even be taking sulforaphate, so ask the question. And then you can see the other drugs lower on this list. Those are the ones that have a higher risk for a prolonged QT interval, which is another common aspect of fluoroquinolone prescribing that most test questions want you to know, the boards, and you should just know it. You also see that it can be used for respiratory tract infections and skin type infections as well. The first 2 we talked about, Cipro and Levaquin, are also for inhalation anthrax. We're going to use ciprofloxacin or Cipro, as our prototype drug. Its mechanism of action is interfering with DNA replication and cell division. And as far as the antimicrobial spectrum, it does cover both our gram-negatives and our gram-positives. And it will not, however, help with C. diff. It actually promotes C. diff. Okay, so please keep that in mind when you are prescribing. Most urinary tract pathogens like E. coli, Klebsiella are very sensitive to ciprofloxacin, but this isn't a first-line treatment for UTI unless it's already been proven that there has been some resistance to other drugs, or that they have had recurrent complicated UTIs, and you might want to use this antibiotic instead. It's also great for anthrax, Pseudomonas, Haemophilus influenza, Streptococci, Meningococci, as you can see here. In terms of pharmacokinetics, ciprofloxacin can be given both oral or IV. Most of you will be prescribing in an outpatient scenario, so give the oral prescription. It has a half-life of 4 hours, eliminated by hepatic metabolism and excreted by the renal system. We do know that there are many uses for it. We saw on the previous slide with the big chart, UTI, respiratory, GI, bones, joints, skin, and soft tissue. For anthrax, especially those that have inhaled anthrax, this is the preferred treatment. Because there's concern of tendon injury, I do not give this medication to patients that are under 18, but there are 2 approved pediatric doses to know about: complicated urinary tract infection, kidney infections that are caused by E. coli. A seasoned specialist may decide to go this route. I wouldn't do this in outpatient, but if you have this background and specialty in urology or nephrology, you can consider it. But do remember the adverse effects. And also, it could be post-exposure prophylaxis for someone that has had anthrax or is being actively treated for anthrax. Otherwise, generally, I avoid this drug in my pediatric population. GI reactions are the more common adverse effects that you'll hear about with ciprofloxacin, but if someone's talking about having diarrhea, I want to rule out C. diff because sometimes Cipro can cause C. diff. I'm looking for CNS type reactions like dizziness, headache, restlessness, and confusion. For patients that I am prescribing Cipro for, especially for UTI, I'm asking if they've ever had a vaginal fungal infection, but also this can occur in the pharynx as well. And I'm just trying to rule that out because I might want to give an antifungal prophylaxis while I'm treating them with Cipro. For patients that have seizures disorder, I might want to choose something else. It's rare, but seizures have occurred on ciprofloxacin, and it does pose a significant risk for confusion, psychosis, and other visual disturbances for our adult older patients. Stressing this one more time, although it is rare, fluoroquinolones do cause disruption to the tendon, and the way it does this, in animal studies, it's shown that it disrupts the extracellular matrix of the cartilage. And I've actually had patients that have complained about tendonitis. You have to stop the medication right away. What you are going to hear or see is irritation at the tendon, pain, swelling, inflammation. Additional to this, if they are exercising, you need to tell them maybe to refrain until tendonitis has been ruled out completely. And obviously, if they have tendonitis or tendon pain, they shouldn't be using that area of their body to that extent anyways. The other thing that I always will advise my patients on is the phototoxicity risk. If they go out in the sun, they will get sunburn. They will complain about redness first probably, and then just like how our going out to the beach sunburns happen, they're going to start to feel the pain and the burn. Severe cases, if they don't realize, it can cause vesicles, exudation, blistering, and edema. It's not a matter of putting on sunblock and going out in the sun. It is a matter of not going into the sun at all. Even indirect sunlight and being under a lamp, those things can also trigger the phototoxicity. One more time, just in case you missed it before, ciprofloxacin and the other fluoroquinolones increase the risk for developing C. diff. And if they complain about diarrhea, make sure it's not just diarrhea as an adverse effect because they're having a GI reaction. Make sure it is not developing into C. diff. Another drug worth mentioning here is Metronidazole, which is Flagyl, and it treats protozoal infections only. Well, not only, because it also will treat the obligate anaerobic bacteria. However, it's not going to treat the aerobic bacteria because it doesn't have the ability to activate Flagyl. Only the anaerobes can activate. Once it becomes activated, it's going to interact with the DNA strands, causing a breakage, which then they're going to lose that helical structure. When this happens, it's going to inhibit the nucleic acid synthesis, which will ultimately lead to the cell death. Aerobic bacteria don't have the power to do this. What is Flagyl going to cover? It's really good for C. diff. And you can see here the other species of anaerobes that it will cover, but C. diff is the one that is kind of what you're going to see the most of. It can include infections of the CNS, abdominal organs, bones, joints, skin, and soft tissues, as well as the genitourinary tract. Again, only the anaerobic or the obligate anaerobic bacteria.